you so much for coming for today's presentation. So today we'll be discussing the intersections of mass incarceration and public health. So to kind of give some background, so the origin of this work started from a collaboration between our time here at the University of Minnesota School of Public Health and collaboration with Jason Soul, who's over at the Hamline University in the Criminal Justice and Forensic Science Department. So part of this presentation came from where we introduced this topic as part of a screening of the Beyond Walls, which is a series of 5 short films which document what the prison industrial complex and abolition and what that means. So today we're excited to continue this work and kind of raise awareness of mass incarceration in the sphere of public health.
Hi, everybody. My name is Sonia Meidels. I use she, her pronouns. And as Ellen shared, I just graduated my MPH from the University of Minnesota in the Community Health Promotion Program.
Thanks for being here today. My name is Mackenzie Farrington. My pronouns are she, her. And similarly, like Ellen said, I just graduated from the U with my dual degree in social work and public health with concentrations in community practice and community health promotion.
And I'm Sibram, he, him, and also a recent graduate of the Community Health MPH program here at the University of Minnesota. So before we begin, we just want to establish some shared agreements and understandings of today's presentation. So first, this is a very complex issue, and we're only here for an hour. So this presentation is only like a high-level overview of mass incarceration and public health. And so we're not going to be able to cover everything. So you may leave here with some more questions than you have answers, lacking closure. You might feel some tension or feel challenged on your beliefs. And we ask that you approach that with curiosity and humility. We also ask that you recognize and respect the lived experiences of others and recognize that as knowledge. And of course, at any time, make sure you take care of yourself. So feel free to step away at any time to address your needs. Lastly, we want to center this discussion in the belief that liberation is possible. So we put together this document that defines some of the terminology. You can scan the QR code here if you have maybe your device readily available. Otherwise, I will go ahead and include a link in the chat. So that just includes some of the terminology we'll be discussing today. Let's give a few folks a few more seconds. Okay. All right, so here are some of the objectives of what we hope you take away from today's discussion. So first, we want to recognize the history. We want everyone to be able to recognize the history of incarceration in the United States and its disproportionate impact on marginalized communities. Understand the roles of our system of government, healthcare, and public health in generating equity. And lastly, identify how mass incarceration impacts the health and well-being of individuals and communities. So to give you a brief snapshot, there are nearly 2 million people held across thousands of federal, state, and local facilities today. If you include those in community supervision programs such as probation and parole, that number soars to over 5.5 million people under the control of the prison industrial complex. So to again, I give you a global perspective, 1 in 5 people who are incarcerated in the entire world, 1 in 5 of them is incarcerated within the United States. Additionally, there are currently over 30,000 people held in immigration detention centers, with 180,000 additional more being monitored. And of those who are currently detained, the majority do not have a criminal record. So with such large numbers, it's important to remember that these are each individuals who are caregivers, children, have chronic health conditions, and have so many other identities and conditions which are impacted by incarceration. So as public health professionals, it's vital that we do not neglect this population from our work. So to understand mass incarceration, we need to understand its roots. So the seeds of mass incarceration were planted in 1865 with the passage of the 13th Amendment, which barred the practice of slavery except as a punishment for a crime. So in the late 19th century, Black codes and Jim Crow laws targeted Black Americans, resulting in overwhelming representation in Southern prisons. As Black populations increased in Northern prisons during the Great Migration, so did Northern prison populations. So in the first half of the 20th century, racial disparities in prison populations roughly doubled in Northern states most affected by the Great Migration. So in the 1970s, you'll see the US prison population was roughly 200,000. And over the next 30 years, it would more than triple. Law and order and tough on crime was the prevailing response to social unrest and crime, which kind of focused on harsh punishment as a deterrent. So policies such as mandatory minimum sentencing, three-strike clause, and extensive use of life without parole have since left people in prison for extremely long periods of time. Today, 1 in 7 people incarcerated in prison has a life sentence, which is larger than the entire prison population in 1970. So when you see this graph of the US prison population over time, you may notice on the very right side, a very promising dip at the end. However, this drop is largely contributed to pandemic-related pandemic-related factors, such as drops in most types of crime, court delays, temporary transfers, suspensions of transfers from local jails, none of which were intentional efforts to end, none of which were intentional efforts to reduce the prison populations. So this trend in a declining prison population has not yet been permanent either, as prison populations and jails have already begun to rebound to pre-pandemic levels. While many of the policies that have fueled mass incarceration and the war on drugs were written by seemingly race neutral, they disproportionately affected and targeted communities of color. Currently, Black Americans, Latina Americans, and Indigenous people still face significantly higher rates of incarceration compared to white Americans. So in this graph, you will see some clear income disparities between race, gender, and incarcerated groups. As a parent, often those who end up incarcerated are low income. And incarceration can have long-lasting effects on our well-being well beyond prison. So currently, about 79 to 100 million people in the United States has a criminal record, which is roughly 1 in 3 adults. Having a criminal record can be a huge barrier to everyday life, from voting, housing, employment, and so on. So this exclusion from social, economic, and educational opportunities can leave people trapped in poverty. Incarceration can have lifelong financial implications, with one estimate with people losing over half in annual average income earnings for someone with a felony. And it's estimated that had mass incarceration not occurred, there would have been a 20% reduction in poverty nationwide over the course of the past few decades. So here we're kind of talking a little bit more about some of the myths in prisons. So first, we're talking about like violent versus nonviolent crimes. So the majority of people held in state prisons have been convicted of violent offenses. So despite the kind of seemingly clear dichotomy between violent and nonviolent, these labels can be oversimplify and ignore some of the complexities and circumstances of events that led to a violent conviction. So typically the distinction between violent and nonviolent is understood as like serious and non-serious. However, this label of violence can be applied more broadly than what we may consider a violent act. Many crimes that do not involve any physical harm can result in a conviction of a violent offense, depending on the state and federal law. In some states, burglary, which is an unlawful entry into a dwelling, can be considered a violent crime, but very few burglaries result in any physical harm. And many of the reform and release efforts over the past few decades have focused on those with nonviolent offenses. But in order to truly transform how we treat people who are incarcerated, we must expand that scope. So while it may be easier to recognize the humanity of those convicted with nonviolent offenses, our misunderstanding of this legal distinction kind of excludes nearly half of the current prison population. And we understand many of the factors such as age, environment, inequality, and poverty that factor into violence. And yet people are still held in prison for long periods of time and condemned to have violent tendencies and histories, which excludes them from many aspects of life. And this sort of ignores some of the contextual factors and, of course, later risk in adulthood. And just to be clear, this is an attempt to minimize the real harm caused by someone's actions, but want to bring attention to a system which compounds harm and violence. More attention needs to be paid to public health and community-based approaches, which can more effectively address the roots of violence. The next myth we want to address is the myth of private prisons. So it's a common misconception that private companies are a driver for mass incarceration. So currently, of those incarcerated, only 7% are held in privately run prisons. So a better understanding of, or a better perspective of private prisons more so as a leech on this system of benefiting from exploitation. So private prisons, the rise in incarceration is driven by the government, not necessarily just by incentives of privately run prisons. But of course, exploitation in the criminal justice system still exists, as is apparent in the form of low to no wages, cost and quality of communications for people who are incarcerated, cost of commissary goods like the store in prisons, and people who pay for their own probation services, like many times people have to pay for their own monitor devices and things like that, which shift costs away from the system and benefit private contractors and vendors. So prison labor is another case of frequent exploitation of people who are incarcerated. So the majority of people, 80%, who are incarcerated may work to maintain the same facilities which confine them, such as laundry rooms, kitchens, and other prison services. People in some prisons can also get public work assignments, such as grounds and buildings maintenance, road maintenance, and wildland firefighting. Many states, actually all states except Alaska, also operate their own prison industries, which produce goods and services at low cost to public entities. So less than 1% of people employed in prison work in private industries, but these jobs, when are available, are highly coveted as they provide higher wages. However, people lose most of their wages to the prison as payment for room and board. Working conditions can also be poor and dangerous, and wages can make basic commodities like commodities and services such as phone calls unaffordable. So as I've discussed, the prison industrial complex was not created to keep us safe, but by locking away people who we seem are unfit for society, but to systematically suppress and dehumanize those deemed undesirable under white supremacy. It is the imperative of public health to promote the health and well-being of all, and is long overdue to invest in our communities, which truly keep us safe. So next, you're going to hear from Sonia, who's going to tell you more about the public health implications.
Thank you. So before we start talking about public health, we first need to define health. So who defines health and how it's defined greatly impacts our research, policy, and practice. Your definition of health can drive how you understand and address healthcare and health disparities. And everyone's definition of health can be different, but here is one to ground us for now. Health is the dynamic balance of physical, mental, social, and existential well-being and adapting to conditions of life and the environment. Next slide, please. So what about public health? I do recognize that I'm likely talking to many people who work and study in public health, but want to have a shared understanding for the sake of this conversation that we're having. So broadly, the goal of public health is to promote and protect the health of all people in their communities by using evidence and science to strive towards a reality where everyone is safe to live, learn, work, and play. The focus is on preventing problems through implementing education programs, recommending policies, administering services, and conducting research. Given that public health focuses on promoting the health of all people, health equity is a core value. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And to do this, we must address historical and current injustices, overcome economic, social, and other obstacles to health, and eliminate preventable health disparities. And as CRIM has shown, there are major disparities and inequities in incarceration. Next slide, please. Now I'm going to show the intersection of mass incarceration and public health explicitly. So people that are incarcerated are often dehumanized and thought of as less than compared to those that have not experienced the carceral system. So it's important to make explicit that incarcerated people are people and their health matters. So given the large-scale expansion of the carceral system, especially over the last 40 years that CRIM talked about previously, it's considered a major contributor to poor health and communities with severe consequences. And because of this, it is considered a social determinant of health. Generally, social determinants of health are the non-medical factors that influence health. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. They are unjustly distributed in society and therefore are major contributors to health disparities. So how about the public health focus on this issue? I want to make sure it's clear that community members, currently and previously incarcerated folks, advocates, and organizations have been fighting against mass incarceration for decades. But what about the public health as a profession? So, some of the first times incarceration was conceptualized as a public health issue by the profession at large was in around the mid to late 2000s. And this includes discussions, research, and actions from the American Public Health Association and a couple incarcerated related objectives in the Healthy People Initiative around this time. And there was also a renewed call for focusing on mass incarceration as a public health issue during COVID-19. And although the profession of public health has started to view mass incarceration as a public health issue, public health institutions, both academic and professional, often still rely on the criminal legal system to address public health issues such as gun violence, homelessness, substance use, and mental health crises, which perpetuates the cycle of criminalization. And the extensive harms of mass incarceration are rarely discussed in public health curricula, including at the University of Minnesota. So there's still a lot that we can still contribute to addressing these historical and current issues. Next slide, please. So now I'm going to talk about how the criminal legal system has become an institution that both reflects systemic and institutionalized oppression and drives these inequities. So to showcase this, I'm going to talk about healthcare quality, overcrowding, solitary confinement, and environmental justice. So healthcare quality. People in correctional facilities are the only group in the United States with a constitutional right to health care. Unfortunately, the quality, availability, and organization of these health services is not well documented. However, it is clear that the standard of care lags far behind community health standards, and only 17% of the correctional facilities are accredited for healthcare service standards. So, in effect, this provides minimal oversight and a lack of uniformed quality standards for health services in these correctional facilities. Relatedly, I'll talk about overcrowding. So by the end of 2020, 1 in 5 state prisons were at or above capacity. This overcrowding leads to double and triple bunking, expanded waiting lists for education and drug treatment, reduced access to meaningful work opportunities, and increased use of solitary confinement. It also has severe consequences for the spread of infectious diseases like COVID-19. By July 2023, as an example of this, there have been almost 650,000 infections and 3,000 deaths in America's correctional facilities. Next slide, please. So now I will share a few headlines from Minnesota and nationally to show the impact of overcrowding and other public health concerns within correctional facilities that started in 2020. So this first headline, published in 2020 by the Associated Press, highlights the concern over the spread of COVID-19 in part due to overcrowding. Governor Walz is quoted here saying, "We all know what our antiquated and overcrowded prison system is just a hotbed for some of this to happen." Next slide. The next two articles, the Kara Levin article is from November 2020 and highlights that the Minnesota prison system was facing one of the worst COVID-19 outbreaks in the nation around this time. The state ranked 6th highest in infection rates among the incarcerated in the country and 3rd among corrections staff. Now, just 1 year later, in November 2021, we see this article from the St. Cloud Times. Earlier in the month, the St. Cloud Correctional Facility had to close their intake operation due to such a high spike in COVID-19 cases. And so for some context, the facility is usually the primary intake center for the entire Minnesota prison system. So this had quite a large impact on that whole process. And at that time, the facility accounted for more than 94% of the current COVID-19 cases in Minnesota prisons. And so this article goes on to mention that there are several factors that likely contributed to this, many of which are related to public health concerns. Next slide. So now at the federal level, this article written in 2023 from Stat News highlights 4 key points of the COVID-19 response in federal prisons. So here's a quick summary of that. So when rolling out vaccinations, prisons that had high-risk patients did not prioritize them. Federal prisons weren't proactively testing residents to prevent outbreaks. The Bureau of Prisons accounting of its own early COVID-19 response is incomplete. And federal prisons had a slow booster rollout. Another troublesome fact that adds to this issue and is somewhat implied in this article is that based on an article by the Prison Policy Initiative in April 2021, most prison staff had refused to be vaccinated, leaving vast numbers of incarcerated people who have been denied the choice to protect themselves at unnecessary risk. The median vaccination rate, having at least one vaccination, was only 48% of prison staff, with some states as low as 10%. And so I mention this to highlight that the public health response to COVID-19 within prisons was not just like located in specific areas, but it was a systemic issue. Next slide. So now I'm going to talk about solitary confinement, something that the US uses more than any other country in the world. So solitary confinement, which is sometimes referred to as restrictive housing or segregation, occurs when people are housed in single cells. They're segregated from the general prison or jail population, and they're restricted to their cell for 23 hours a day. They have really limited access to natural sunlight or any human interaction, be it like in person, phone calls to family, loved ones. That is all very limited. And so often people assume that solitary confinement is reserved for the most serious violent behavior, which it is used for that. However, it's more often used in response to low-level nonviolent behaviors such as swearing, smoking, disrespecting authority, or possessing minor contraband. And disciplinary policies vary across corrections departments, but based on a study by the Vera Institute, the most common theme is that a large range of behaviors can lead to placement in solitary as a disciplinary action. Some systems don't place any restrictions on what disciplinary actions can be used. Additionally, many people with mental illness are in restrictive housing, often as a result of behaviors associated with mental illness. So, for example, many systems punish self-harm or suicidal behaviors with restrictive housing. And subjecting a person to more than 10 days of solitary confinement results in a distinct set of emotional, cognitive, social, and physical pathologies. And more than 15 consecutive days in solitary confinement is considered torture by the United Nations Mandela Rules. Now, bringing it back home to Minnesota, in 2019, prison officials sent 60% of the prison population to solitary confinement in that year of 2019. And of those, they disproportionately sent Black and Indigenous people to solitary. So this example highlights how the practice is a reflection and driver of oppression and inequities. Now, there is an effort in Minnesota and other states to abolish solitary confinement and reform segregation, but there is still a lot of progress needed. Next slide. So lastly, I'm going to talk about environmental justice related to the criminal legal system. And incarcerated folks are often disregarded when discussing environmental concerns, which highlights an ongoing human rights crisis due to the extra environmental hazards imposed on top of unsafe confinement conditions. So here are some ways in which this shows up. About 1/3 of prisons are located within 3 miles of federal Superfund sites, which are the most seriously contaminated places needing extensive environmental cleanup. Research warns against spending any significant amount of time near these Superfund sites because the proximity to them is linked to lower life expectancy and a whole list of serious health issues and illnesses. Additionally, beyond the Superfund sites, generally, prisons tend to be located in communities that are more polluted. And many prisons and jails have old, rundown infrastructure, similar to what Governor Walz highlighted in that article. They're not updated, which leads to poor water and air quality. And there have been many examples of currently incarcerated people protesting their dark-colored water and other concerns over their safety, including some recent examples here in Minnesota. And now testing for and mitigation of radon is not a priority in prisons. So radon is an invisible, odorless gas known to cause lung cancer. And the US government in the 70s and 80s took a firm stance to eradicating radon. But as recent as 2018, a court found that Connecticut prisons was knowingly and recklessly exposing its incarcerated population to high levels of radon, showing how eradicating radon is not a priority for those that are incarcerated. And lastly, correctional facilities have also shown poor disaster planning, for example, from hurricanes, with some leaving facilities out of evacuation plans altogether. So these examples of environmental injustices show how incarcerated people are involuntarily subjected to these environmental burdens they aren't able to escape during the period of their incarceration. So the four examples I provided, healthcare, overcrowding, solitary confinement, and environmental justice, are just some of the ways that correctional systems are a reflection of oppression and driver of inequities. And there are many others, all of which lead to poor health outcomes. Next slide. So lastly, I'm going to talk about recidivism and its relation with public health and social determinants of health. So after someone is released from prison, recidivism is defined as new justice system conduct, such as technical parole violation, arrest, conviction, or incarceration. It's often used as the sole measure of post-release success. However, it overlooks the broader aspects of reentry, including factors like education, employment, housing, family support, mental and physical health, community engagement, and personal well-being. Similar things that Stephen had mentioned earlier as far as impacts. So, and although recidivism is limited, I am including some data just to highlight the cycle of the carceral system and how it's part of the social determinants of health. So it also shows the need for progress in addressing the complexities of reentry. Based on a 10-year study of 24 states, about 61% of people released in 2008 returned to prison within 10 years for a parole or probation violation or a new sentence. Here in Minnesota, the Hennepin County jail recidivism rate is quite high at 87%. Now, recidivism rates can vary widely, and these statistics only scratch the surface of the challenges within the carceral system related to reentry. And now I'll pass it off to Mackenzie, who will share about the impacts of mass incarceration on health.
Thanks, Sonia. So as Sonia just mentioned, we're going to transition into a brief discussion about the impacts of mass incarceration on both individuals and communities' health outcomes, starting with the impacts on physical and mental health. It's critical in this conversation to remain grounded in the fact that Black and Indigenous communities and communities of color experience disproportionately worse health outcomes during and following incarceration. During and after incarceration, folks face worse physical health outcomes compared to the general population and have a higher risk of death. They're more likely to have a variety of health conditions, both infectious and non-infectious, but can bring infectious diseases home with them, putting their families and communities at risk too. However, this population faces barriers to receiving healthcare during reentry, even with insurance, due to factors like internalized stigma and discrimination against patients with records. A disproportionate number of people with mental health disorders are in prisons and jails, but incarceration itself also creates and worsens mental health due to the environment and contextual factors surrounding incarceration, such as solitary confinement, like Sonia mentioned. Additionally, the term post-incarceration syndrome refers to the idea that people continue to suffer the mental health effects of incarceration even after they're released and outside of the actual environment of prison. So mass incarceration can also have impacts on youth who are involved in the system. Being detained as a youth negatively impacts the young person's long-term mental, physical, and social health outcomes, and youth incarceration has disproportionate impacts on Black youth and youth of color. There are currently mixed results regarding the impact of youth incarceration on adult incarceration, but there's a potential association. Beyond Black, Indigenous, and communities of color, Mass incarceration also has disproportionate impacts on other marginalized communities. For example, LGBTQIA individuals are overrepresented in prisons and jails, which increases the negative impacts in this community and poses barriers to finding housing, employment, social benefits, and healthcare after incarceration. Incarceration also creates the conditions for accelerated aging, which means that people who are or have been incarcerated face more chronic and life-threatening illnesses earlier in their life than typically expected. The physiological signs of aging occur in people who were incarcerated at younger ages than typically expected to see these physiological signs, and people who are or were incarcerated have a lower life expectancy. Older adults also face many barriers to successful reentry after incarceration. They have fewer relationships and social support. They face discrimination in healthcare and nursing homes. They face extra employment barriers due to both criminal records and ageism. They're navigating potentially new and unfamiliar technology. They're at a higher risk for houselessness, and there are more difficulties accessing benefits like SSI and Medicare. Similarly, cisgender women are at extremely high risk of death post-release compared to cisgender women who have not been in prison. Women also face more barriers and challenges during reentry compared to cisgender men, which is associated with recidivism. There are fewer reentry programs available to women to support them. They face greater financial burdens and family responsibilities, and there are disproportionate income disparities and housing insecurities.
So as we discussed, conditions in prisons and jails can exacerbate existing health conditions. So given the higher prevalence of disabilities in prison compared to the general population, there must be special concern for accessibility and disability rights while incarcerated. So despite federal mandates that Sonia discussed, those with disabilities in prisons and jails face many challenges, which impose further isolation, vulnerability, and discrimination. Things like access to prosthetics, sign language interpreters, assistance with filling out and understanding forms, and so on are some of the many challenges that people with disabilities face in prison and jails. Educational and vocational programs can be an important part of the intellectual and social needs of those who are incarcerated. However, the lack of available accommodations can restrict access. And as Sonia discussed, the quality of healthcare in prison is already limited, and this continues to narrow for those with disabilities. Communication both inside and outside of the prison can be also extremely difficult, further isolating those with disabilities. Lastly, conditions in prisons and jails can be detrimental to health and well-being, with some facilities, as Sonia discussed, utilizing segregation and solitary confinement to separate those with disabilities. This can leave them vulnerable to abuse and neglect, compounded by the barriers created by the inaccessibility of legal challenges and appeals.
Children also might face disproportionate, negative health outcomes due to their parents' experiencing incarceration. Parental incarceration has been linked to negative outcomes for children's development and well-being at all ages and developmental stages. During both early childhood and throughout elementary school, children who have parents or caregivers who are incarcerated are less ready for school, are more likely to have problems in school, and they face a variety of emotional and behavioral challenges. There are similar impacts on adolescents, but the impacts and consequences become more serious. For example, the consequences for behavioral challenges, particularly in school settings, become more severe. Adolescents might face long-term or permanent expulsion from school, mandatory enrollment in alternative school settings, or incarceration in juvenile facilities, all of which fuel the school to prison pipeline. People who had a parent or guardian in the carceral system experience the impacts into adulthood, as it's associated with foregone healthcare, prescription drug overuse, a higher likelihood of emergency department use, and injection drug use. These trends are all worse for Black and Latina youth, not because of the youth's actions, but because of the systems that CBRM has discussed that we've created and uphold. So the prison industrial complex does not rehabilitate individuals. Instead, it perpetrates further harm on individuals, families, and communities, having profound negative health effects on millions of families and contributing to recidivism. However, the impacts of the reentry process are much more broad than just recidivism rates. There are collateral consequences to individuals, families, and communities during the reentry process. Reentry is hard, and we are not setting up people for success. Policies have created barriers to critical social supports and necessities like employment, public benefits, voting, housing, education, and healthcare. For example, discriminatory housing policies make people who have been incarcerated nearly 10 times more likely to experience houselessness than the general public, which comes with many additional public health implications. Family reunification in this period is also difficult. Families provide crucial social support and can ease reentry pains and difficulties, but the relationship between family engagement and reentry is complex. Supporting a returning family member can be stressful, exhausting, and draining. There is greater impact on Black and African American communities during this reentry process, and all of these factors impact individual and community health outcomes. Lastly, mass incarceration has broader public health impact on the community at large. Concentrated incarceration refers to communities with large amounts of people cycling through jails and prisons due to the structural factors that Seabram discussed earlier. These communities face the impact of mass incarceration on that broad community level scale. High rates of arrest and incarceration damage social networks and relationships and negatively impact long-term life chances, children's health outcomes, family functioning, labor markets, and economic and political infrastructures. So we just spent some time highlighting some impacts of mass incarceration on public health, but we acknowledge that there are many more experiences, intersections, and complexities that we could and should be discussing that we did not have time for, such as the experience of trans and non-binary individuals in prisons and jails, or more impacts of the carceral system on like the nervous system and trauma. So we've discussed the intersection of public health and mass incarceration, but what does this mean for our field moving forward? In October of 2021, the American Public Health Association, APHA, adopted a policy statement regarding advancing public health interventions to address the harms of the carceral system. This is a direct quote from the policy's recommendations section. It states, APHA recommends moving toward the abolition of carceral systems and building in their stead just and equitable structures that advance the public's health by 1, urgently reducing the incarcerated population, 2, divesting from carceral systems and investing in the societal determinants of health, like housing and employment, 3, committing to non-carceral measures for accountability, safety, and well-being, 4, removing policies and practices that continue to harm formerly incarcerated people, including in the areas of housing, employment, and voting, and 5, funding research to evaluate policy determinants of exposure to the carceral system and proposed alternatives.
So in summary, we've covered a lot of information, but we identified how this country has created an institution of mass incarceration and how it has negatively impacted the health of individuals and communities, which inherently makes this a public health priority. So next, we have a few discussion questions for you. So we're going to split up into breakout groups for about 10 to 15 minutes, and then we'll come back together for the last few minutes for any reflections or questions. So those questions, I'll read them off real quick. And we'll also drop these in the chat so you have a chance to take a look at them as well. So just kind of talk about what are your initial thoughts and reflections? What tensions does this topic bring up for you? How have you seen this topic come up in your work, courses, or community? How can you see your work intersect with this, with the impacts of mass incarceration? And how can we reimagine a public health system which can meaningfully contribute to the work of building equity and abolition of the prison industrial complex? So I will go ahead